Good evening, everyone, and welcome to today's wonderful revision of pathology. So, if you look at the recent NEETPG 2024 question paper, a lot of image-based questions, clinical vignette-based questions, long questions. So, all our revision should be based upon a compendium of high-yield facts. So, if you look at pathology, there are about 4,000 high-yield facts. I created what is called as a tweet ebook for you to do the revision of these high-yield facts. And tweets are the short sentenced single liner high-yield facts. These 4,000 high-yield facts, you will take around 20 to 25 hours to do the revision. And once you do that revision, you are ready for the exam. So my job is to every day become your classmate, at least 1 hour spend time with you and inspire you to consume all these 20 subjects got 20 tweet ebook PDFs, which I will give you when you join our 6 months course. So let us make the great beginning, doctor. Today in the pathology, let us have a little rapid fire of the image-based questions, images commonly tested in exam. So doctor, what is this? You need to realize it is the Ashkoff's bodies, which you see in the case of the rheumatic fever, the histopathology you need to recognize. Can the online students can punch? Is the voice loud and clear for all of you, doctor? Yeah? Now, so what are you seeing here? This is called the asteroid body. Asteroid body typically has got a, typically has got epithelioid and giant cells in the cytoplasm of the epithelioid giant cells. There are eosinophilic stellate or spider-like asteroid body, and it can contain the calcium. So asteroid bodies can be there in case of the sarcoidosis is what you need to basically understand. Now, what is this called as? This is called the Bunina body. Bunina body. Bunina body. So Bunina bodies are typically seen in amyotrophic lateral sclerosis. LMN features in the upper limb, UMN features in the lower limb, typically constitute the amyotrophic lateral sclerosis, where Bunina bodies is what you need to remember. Bunina bodies are found, right? Now, what are these called as? Hirano bodies. One of the favorite questions of the examiner. Where do we see? Hirano bodies. So this kind of Hirano bodies, we see it in the case of the Alzheimer's disease. We see in Alzheimer's disease is what you should remember. Then what are these? These are called Mallory bodies. So this is also called as a bent rope-like appearance. Bent rope-like appearance. The Mallory body is histologically, which you should know, typically are present in alcoholism and malnutrition is what you should understand. Now, this is the postmortem brain biopsy in a patient who had subacute sclerosing panencephalitis. It's a late complication of the measles. So typically, we find what are called as Cowdrey type A inclusion bodies in case of the subacute sclerosing panencephalitis, which is the feature of the measles. A late complication is what you should know. Now, all of you know, in the rabies, we find Negri bodies. So where do we find Negri bodies, doctor? We find it in hippocampus. Hippocampus, we find the Negri bodies, and what you are seeing here typically are the Negri bodies, which are oval shaped bodies. very often found in hippocampus. Hippocampus is the part of our limbic system. Amygdala, hippocampus, they're all involved in the part of the Pepys circuit, which is the part of the limbic system, is what you should understand. Then what is this typically? These are called, in the cytomegalovirus, you get basophilic intranuclear inclusions, which are the Cowdery bodies surrounded by a halo. You can see there is a halo which is surrounding the Cowdery body, which is basophilic in case of the cytomegalovirus infection, is what you need to remember. Now, these are called councilman bodies, very important. So tomorrow's exam, they will give you the histopathological picture of each of these bodies, which you should recognize. So the councilman bodies, and you can see the ballooning of the hepatocyte, which is classical feature, which you see in the case of the acute viral hepatitis. Acute viral hepatitis is what you should remember. Now, you are able to see these grape-like inclusion bodies, which are called as the Henderson-Patterson bodies, is what you should remember. Henderson-Patterson bodies. Where do you see, doctor? We see it in case of the molluscum contagiosum, is what you should remember. Now, can you see an owl? Yes, sir. So this owl-like inclusion bodies, where do you see? Owl appearance of the inclusion bodies is the feature which you see in the case of the cytomegalovirus histopathologically. Then trap. What is the trap, doctor? Trap. Tartrate resistant acid phosphatase staining. Tartrate resistant acid phosphatase staining. So where do you get that? Trap positive cells are found in hairy cell leukemia. So what is a very classical feature of hairy cell leukemia? In hairy cell leukemia, bacho, we get a massive splenomegaly, right? Massive splenomegaly, because the splenic infiltration of these hairy cells. And if you do the bone marrow aspiration, you get a dry tap, which is very characteristic of hairy cell leukemia. Another important point about HCL, hairy cell leukemia, that you need to remember is we use cladribine. Cladribine in the treatment of hairy cell leukemia is what you should remember. Then all the myeloid, there are two types of leukemic cells. One are called myeloid, other are called lymphoid. माइलॉइड में क्या होता है? माइलॉइड में ऐसा इंक्लूशन बॉडी होता है जिसका नाम है और rods. What are they called as? Or rods, which are very classical of myeloid series, is what you need to remember. So every NEETPG, FMG, INICET, USMLE, any exam you go, leukemia, lymphoma, without that, there is no question paper. Now, doctor, Lewy bodies. So you can see Lewy bodies. Lewy bodies are the classical feature which you see in the case of the Parkinson's disease, is what you need to understand. So all these histological hallmarks are the favorite question of the examiner. So where do you see myoglobin casts? Typically, these are all what? Myoglobin casts histologically. You can see the myoglobin casts if you do the electron microscopy. So myoglobin casts are the feature of rhabdomyolysis. Rhabdomyolysis में होता है myoglobin casts histologically, which you need to remember. Now, the urine examination, it is called poor man's renal biopsy. Poor man's renal biopsy. So typically we get muddy brown casts, as what you can see. Muddy brown casts are the feature of acute renal tubular necrosis may. You get muddy brown cast is what you should remember and how to recognize. Then once there is nephrotic syndrome, proteinuria, hyperlipidemia. So in these nephrotic syndrome patients who also have hypercoagulability, you should know in the complete urine examination what you get, lipid droplets in the urine, right? So fatty casts, what do you get? Fatty casts are the feature of nephrotic syndrome where you find the fatty casts is what you should know, and they have a Maltese cross appearance is what you need to remember. Now, these are the lesions, the hemorrhagic lesions, which you are able to see. You are able to see here also. What are these called as? Janeway lesions. Janeway lesions are the hallmark of infective endocarditis is what you should remember. You should know how to recognize it in the exam. This is another classical example of the Janeway lesions. You can see the hemorrhagic lesions which are called Janeway lesions. Now this is called the crew cut appearance. So whenever there is an expansion of the outer diplo, where the skull diplo is involved in the hematopoiesis, in the case of the conditions like thalassemia, sickle cell anemia, etc. So you find the crew cut appearance, which you should recognize tomorrow in the NEETPG when an MCQ is image based and given to you. Now, whenever hemochromatosis is there, hemochromatosis will lead to pancreatic dysfunction, leading to the development of the diabetes. And hemochromatosis also lead to a bronze-colored discoloration. So that is the reason it is called as bronze. It is called bronze diabetes is the name given to the hemochromatosis is what you should remember. Now, these are called the target cells. Can you see the target with the central darkness? So, target cells are the feature which is very classical feature in case of thalassemia. So, complete blood picture, CBP appearance in pathology is one of the favorite image-based questions in the tomorrow's NEETPG, INICET and FMGE exam, doctor. Then, whenever hyperparathyroidism is there, parathyroid, what it will do? It will lead to the dissolution of the bone. So, that lead to cystic appearance of the bone because of its dissolution due to excessive parathyroid. It is called osteitis fibrosa cystica, which is seen in case of hyperparathyroidism. You see this appearance which is called, typically you can see the cystic lesions, right, doctor? Cystic lesion is there. Here also there is a cystic lesion classically, which is called osteitis fibrosa cystica, which is seen in the case of the hyperparathyroidism. So, whenever there is Whipple's disease is caused by Porphyria whippleyi. So, what is a very important histopathological hallmark of the Whipple's, doctor? PAS. The PAS staining, right? Periodic acid shift stain positive macrophages. So you can see PAS positive macrophages whenever you do the intestinal biopsy in case of the Whipple's where the patient presents with malabsorption. Whipple's can lead to arthritis. Whipple's is a multisystemic presentation, right? So whenever you do the biopsy, PAS positive macrophages are very classical feature in case of the Whipple's disease is what you should remember. Now, this is called the Gover's sign. So, where do you see in Gover's sign, doctor? Whenever there is any muscular dystrophy. So, the child is lying down, and when you ask him to get up, first he will take a turn, then he'll take a turn, then he will use his both limbs, then he will raise his back because of the proximal muscle weakness. Then slowly he will get up. As such, he is ascending, climbing up his own body, which is called the Gover's sign, which is the classical feature in case of the muscular dystrophy. So where do you see honeycombing appearance? There are many conditions where you see, but you need to know pneumocystis carinii pneumonia lead to the development of the honeycombing appearance of the lung. So whenever there is a tuberculosis, there is a lymph node, right? So Ghon's focus is indicative of the primary tuberculosis is what you need to remember, the Ghon's focus. Now, what are the 4 anterior mediastinal tumors, doctor? You can see this is all the anterior mediastinum. So what are the anterior mediastinal tumor? 4 T's you need to remember. T for thymoma, T for teratoma, T for terrible lymphoma, T for retrosternal thyroid. So the 4 T's that you need to remember when it comes to anteromediastinal mass, and you should recognize the thymoma. So whenever thymoma is there, what is the common association of thymoma, doctor? Thymoma can be associated with myasthenia gravis is what you need to understand. Then this is the Crohn's disease. In Crohn's disease, what do you find? Non-caseating granuloma. You are able to see, right? This is called non-caseating granulomas are the hallmark of Crohn's. Whereas in ulcerative colitis, what do you see? You find a lot of infiltration, localized infiltration with the leukocytes, which are called crypt abscesses, are the classical feature of ulcerative colitis is what you should remember. Now, what are these nodular lesions when you do the renal biopsy? When you do the renal biopsy, these nodular lesions which are able to see, they are called as Himmelstein-Wilson's nodules are the feature of the diabetes mellitus is what you should remember. This is another example. You should identify this histopathology image, which is a very characteristic feature, which you should not forget. Glomerulonephritis, without that there is no question paper at all. So this is an example of Himmelstein-Wilson's lesion is what you should remember in nodular glomerulosclerosis in diabetes, which is very common finding. Now, you are able to see these nodular swellings which are occurring in the distal interphalangeal joint, doctor. Right? So these are called as Herberden's nodules. They are called Herberden's nodules. So you should know the more proximal are called Bouchard's nodules, and more distal they are called as the Herberden's nodules is what you need to remember. Now, in this malnourished individual, you can see a lot of nodules which are present on the rib cage, which is typically called the rachitic rosary, which is the feature of the vitamin D deficiency associated rickets. And what is this called as, doctor? This is the vasculitis, strawberry tongue. So strawberry tongue, coronary vasculitis, non-exudative conjunctival suffusion. So mucocutaneous lymphadenitis is the name given to the vasculitis, which is called as the Kawasaki disease in the pediatric population, is what you should remember. So now, in a patient of Paget's disease, what is the histopathological hallmark whenever you do the bone biopsy, doctor? There is something called mosaic pattern, because of the irregular bone formation and resorption in Paget's disease. What do you get? Mosaic pattern in case of the Paget's disease. So, for the NEETPG exam, always remember, very high yield content only you should master, you should retain, you should revise, you should recall in the tomorrow's exam. So a lot of coaching centers give big study material. But big study material, is it possible to read, revise and repeat and recall and represent in exam? No. That's the reason always be focused. So totally there are 70,000 high yield facts. All the 200 questions, part will come from this 70,000 high yield facts only. How much time do you take to master this high yield facts, 70,000 high yield facts? At least 200 facts you can do revision in 1 hour. So 70,000 divided by 200 is equal to 350 hours. Every 350 hours, you know how to cycle them, right? So second time, it will be much faster revision. But you need to conceptually approach. First, you need to know what are these 70,000 high yield facts. And that is where you have Dr. Murali Bharadwaj. So please visit our website. So playscore.live. So most affordable, the word affordable is important. The most affordable NEETPG, FMG, INI, CET coaching is what we offer. For the past 25 years, we made 300,000 doctors get inspired. So what we offer, daily live online interactive class. Free, absolutely free. I'll come on the YouTube and then inspire you to study. Then I will give you the video library. So you have around 5,000 short videos, totally 400 hours duration covering the 20 subjects, both the web access and also the app, Score Learning app. Then you have the NEETPG mock test, 50 NEETPG full-scale practice test PDFs I'll give, and also 25 NEETPG full-scale mock tests. Every Sunday we'll have a test and discussion. Then there is the notes. Notes has 70,000 high yield facts in the form of 20 tweet books. Now what I'm doing revision is from this pathology tweet book. And also 10,000 NEETPG PYQs of the last 10 years NEETPG. And 6,000 FMGE PYQs of the last 10 years and 6,000 INI CET PYQs of the last 10 years INI CET in the form of single liners for you to do a rapid revision. And 5,000 clinical case vignettes and 3,000 images that you need to master. So all these notes is available as for a small price of 6,000 rupees because affordability is most important. The NEETPG mock tests, 50 NEETPG full-scale mock tests and 50 subject-wise mock tests and 25 extra every week discussion with discussion. This whole thing for 6,000 rupees. And the video library is given subscription for about 6,000 rupees. So on the top of all these three, the video library, NEETPG mock test and discussion and the notes, we also have a daily class to inspire you, to consume you these contents. So that is what we do by conducting a daily live class. So all our live class sessions are all conducted on our website only. So what you are seeing now, typically we embed it on the website and you can simply click in the evening playscore.live and then join the live session, doctor. And there is a schedule which is available below that. So be part. Today only go and reach out to playscore.live and bookmark it, and every day our broadcast will happen onto that. So doctor, continuing our journey, what are you seeing here when you have done the laparoscopy? In the laparoscopy, you are able to see the streaky gonads. Streaky gonads, primary amenorrhea. Where do you see, doctor? We see it in Turner syndrome, where the karyotype is XO, is what you need to remember. Now, there are certain rosettes which you have to remember their names invariably. So what are these called as? Homer Ritter rosettes. Where do you see? We see it in neuroblastoma, we see it in medulloblastoma, and also the P-net tumors is what you have to remember. Then there is another rosette that is often asked in the NEETPG exam as a histopathological thing in the ocular pathology, is Flexner-Winter-Steiner's rosette. So where do you see Flexner-Winter-Steiner's rosette? We see it in the case of the retinoblastoma and pinealoblastoma. We see the presence of Flexner-Winter-Steiner's rosette is what you need to remember. So what do you mean by trilateral retinoblastoma? When the retinoblastoma involves both the eyes, and also pinealoblastoma is also there, then you call trilateral retinoblastoma is what you should remember. Now, these are called Crookes hyaline body. This is called Crookes hyaline body. So where do you see Crookes hyaline body? Typically in the pituitary gland, we see it whenever there is any Cushing syndrome. Then we see Crookes hyaline body is what you should remember. Then what is this called as? These are called as pearls, keratin pearls, keratin pearls. Keratin pearls are the feature of the squamous cell carcinoma. They are the classical feature, the presence of the keratin pearls you should recognize in the histopathology in the tomorrow's NEETPG exam. Now, you're able to see these cells which are called as Hurtl cells. What are they called? Hurtl cells. Hurtl cells are found in follicular adenoma, and also in Hashimoto thyroiditis also you find Hurtl cells, which is the histological hallmark. Now, in a case of lepromatous leprosy, you find sheets of these cells. You can see here. So the sheets of these cells, what are they called? Virchow cells is the name given to the sheets of these cells, which you see in case of the lepromatous leprosy. Then this is called LE cell. In lupus erythematosus, these cells have a phagocytic function. And what are these called as? LE cells is what you have to remember. Then these are the Langerhans cells. So whenever you get Langerhans cell histiocytosis, how do you identify? Whenever you do the electron microscopy, a Langerhans cell, doctor, it looks like Yvonne Lendl, Boris Becker, like a tennis racket appearance. And we find Beer-Becker granules, which is classical of Langerhans cell histiocytosis. Normally, Langerhans cells have got a phagocytic antigen-presenting cells in the epidermis are Langerhans cells is what you should remember. Now, you have Langerhans giant cells. Langerhans is different from Langerhans. Okay, Ramaya is different from Pullaya. Pullaya is different from Bhimaya. Like that. Langerhans giant cells are found in the epithelioid granuloma. In the epithelioid granuloma, in the conditions like tuberculosis is what you should remember. Then in multiple myeloma, the cells which are loaded with the immunoglobulin, what are they called as? They are called the flame cells. What are they called? Flame cells is the name given, which is typically seen in the case of the multiple myeloma. A lot of times the question is asked, which you need to be very sure about. Can the online students can punch? Is the voice loud and clear for all of you, doctor? Now, these are called the foam cells. What are they called? Foam cells. So, foam cells are seen in xanthoma. Foam cells are also seen in Niemann-Pick's disease. And foam cells contain the lipids, is what you have to remember. Then, these are called Warthin-Finkeldy cells. Warthin-Finkeldy cells are the hallmark of the measles. In the case of the measles is what you should remember. Now, in the kidney, whenever there is a adenocarcinoma of the kidney, what type of cells you find? These are called clear cells. You know, the nucleus is pushed to one end, right? The nucleus is pushed like a signet ring to one end. So the histological hallmark of adenocarcinoma is a clear cell adenocarcinoma is what you need to understand. And these are called, they are looking like the frog and tadpole, right? So they're called tadpole appearance, tadpole cells. So where do you find? In the case of the squamous cell carcinoma, tadpole cells are seen, which need to be remembered. Then these are called the half-Boyer cells. Half-Boyer cells are the macrophages which are seen in the placental villi, right? Placental villi. Now, apoptosis is one of the favorite area. You need to be very sure about the apoptosis, doctor. So, there are two pathways. One is called intrinsic, other is called extrinsic pathway, right? So, in the intrinsic pathway, medicine, radiation, fever, etc. will initiate the intrinsic pathway. So, in the intrinsic pathway, BCL2 is the one which regulates the membrane, mitochondrial outer membrane gets stimulated. That lead to opening of the MPT, leading to cytochrome C activation that will cause the procaspase 9 to become caspase 9 which get activated. Similarly, cytochrome C will cause EPOF1 to stimulate the formation of the apoptosome is what you need to remember. Okay, so mainly remember the keywords in the apoptosis, which is inevitably one question will come on apoptosis in pathology. So BCL2, MOM, MPT, cytochrome C, procaspase 9, caspase 9, EPOF1, apoptosome. These are the things you need to remember. Now, this caspase 9 activation will lead to apoptotic bodies. Then the caspase 9 activation also will cause caspase 3 and 7 get activated, which in turn will lead to the formation of the apoptotic APBDs. Now, the extrinsic pathway, there is a death ligand. Death ligand stimulates the FAS receptor. FAS receptor in turn will cause the TRAD and FAD to make the procaspase 8 activated, to cause the disc activated, that will cause the active caspase 8 that lead to caspase 3 and 7 to get activated, which in turn will cause the formation of the apoptotic bodies. So you should know intrinsic pathway, extrinsic pathway very clearly for the tomorrow's NEETPG exam. Now, once the apoptotic bodies are formed, how will it ultimately lead to the destruction? So, ROC1, PAC2, and LIMK1, you need to remember, LIMK1, PAC2, ROC1. So, they are typically the ones which lead to the apoptotic membrane blebbing. In turn, PANX1, PLEX-B2 will lead to a beaded apoptopodia to form. And in turn, there is something called find me signals are produced by this beaded apoptosome, which lead to the apoptotic body fragmentation. That's how ultimately, without any necrosis, a non-necrotic cell dissolution is called as apoptosis, is what you have to remember. So what is a very important hallmark in the apoptosis, doctor? DNA. Typically, DNA will show what is called as laddering pattern. DNA laddering is the hallmark of the apoptosis, is what you should remember. Now, what will happen? What is the difference between a normal cell and an apoptotic cell? So, normal plasma body membrane will have asymmetry. Whereas in apoptosis, the phosphatidyl serine flips to the outer surface of the membrane. The phosphatidyl choline flips to the outer side, and that leads to the loss of the asymmetry, which initiate a bleb formation, which in turn will take forward the apoptosis, is what you need to remember. Very nice to see Mr. Kumar. Very good, doctor. Can you please punch his voice loud and clear, Kumar, along with the letters in the digital board? Please punch. Yes. Now, if you look at intrinsic pathway, let us look more closely at intrinsic pathway. You have BCL2 and BIM. That in turn will cause back to get activated. That in turn acts on the mitochondria. That causes cytochrome C. Cytochrome C in turn will form procaspase 9 to become caspase 9. And in the process, EPOF1 and procaspase 9 together will make the cytochrome C to convert the procaspase 9 into caspase 9. Caspase 9 in turn will cause the caspase 3. Caspase 3 in turn will cause the apoptosis to happen, is what you need to remember. Now, doctor, this is another way you need to remember, because without apoptosis, there is no NEETPG exam, doctor. That's the reason you need to be sure anything about apoptosis. So, extrinsic apoptotic pathway, what will happen? TNF alpha, FAS-L and trail. They in turn will cause FAD and TRAD to act to form the disc, and in the process, caspase 8 and 10 will contribute. That in turn will cause the caspase 8 and 10 become active and cause the caspase 3, 6 and 7 to wake up, which in turn will lead to the full-fledged apoptosis to get triggered, is what you need to remember. Very nice to see Dr. Hussain. Very good. Can you please comment? Is the voice is loud and clear along with the images which we are discussing on the digital board, doctor? Yes. Now, what initiates apoptosis? You should know a very important point. If a cell has to grow, if it is meant to grow, if the Prime Minister need to continue, then there is a growth factor support. All the members of the parliament should support the Prime Minister. बट इफ द प्राइम मिनिस्टर को अगर गद्दी से उतारना है तो क्या करेगा? ग्रोथ फैक्टर विड्रॉल विल अकर. So for example, interleukin 3 receptor. So once growth factor withdrawal is there, voice is okay. Sir, please discussion of the MCQs images with discussion. Yes. Okay. So factor withdrawal leads to apoptosis by inactivating the survival pathways. So there are some pathways like PI3K, AKT, GSK3, which in turn will let the cells to survive. So there is an interruption to this once the growth factor withdraws, and that initiates the apoptosis is what you have to remember. Then there is something called necroptosis. Necroptosis, RIP1, RIP3 kinase are the two things you need to remember. Very important in the necroptosis is what you should remember. Now, there is something called UPRs, unfolding protein response. It has a connection with the cell death. So, whenever the endoplasmic reticulum is under a severe stress, then there is a sustained protein kinase RNA, PKR, like ER kinase, PERK activation, right? So the moment the more and more number of unfolded proteins are there in the cells because of the endoplasmic reticulum stress, that is a signal for apoptosis to happen is what you need to remember. So whenever the cell is young, the amount of misfolded protein burden is low and the ER stress is less. Chaperones are more efficient. Chaperones are those which cause the protein folding. And there is an increased stress tolerance and there is an adaptive unfolded protein response signaling. So there are images of surgery and OBG images in this year NEETPG. Please conduct image sessions. Yes, this session all started with the images only. These are the final images about the final images on the apoptosis, right? You can go back to the previous part of the same video. So you have a lot of images and clinical cases. Now, once the person gets aged, there is a misfolded protein burden which will increase ER stress, decrease chaperone efficiency, decrease stress tolerance, and the apoptotic UPR signaling will increase, which lead to the development of the apoptosis is what you should remember. So accumulation of the unfolded proteins, whenever it is there, ultimately is the underlying cause for the development of for the stimulation and promotion of the apoptosis is what you need to remember. Now, in some of the degenerative conditions like spinocerebellar atrophy, Alzheimer's disease, etc., what is the main hallmark, cytological hallmark? It is the Golgi body fragmentation is the hallmark feature of the neurodegenerative conditions like Alzheimer's is what you need to remember. Then, yes, so that completes our common revision of most of the image-based things. So I'll quickly go back to our tweet book, right? Our tweet book. So once you joined with us, we will give you 20 subjects called tweet books. Tweet books are fundamentally single liners. So they're all single liners that you need to master. So most of these Just now, I ran a image gallery is based upon these single liners. So shall we run through them? You can easily revise 200 single liners in 1 hour. Let us start. So please do download our tweet books, each containing 4,000 to 5,000 single liner tweets, which are a quick way to do the revision for the NEETPG. So Ashkoff bodies, where do you see? Rheumatic fever. Asteroid bodies, sarcoidosis. Bunina bodies are specific for amyotrophic lateral sclerosis. I have just before shown you how the Bunina bodies look on histology. Hirano bodies, just now we discussed Alzheimer's disease. Mallory bodies, alcoholism and malnutrition. Cowdrey type A bodies, in case of the measles with subacute sclerosing panencephalitis. So don't go through the notes, which is like paragraphs full of notes. So that is the reason we organized. There are 4,000 yield facts, sharp and crisp, which you need to master in the subject of pathology. So that is the concept of a tweet book. So for all 20 subjects, there are 20 tweet books, which we will offer you when you join for our course and subscribe. So councilman bodies, you see it in yellow fever, in acute viral hepatitis. Corpora amalasia, typically they are the degenerative nerve fibers, which you see in the cotton wool spots. Then whenever cell necrosis is there, like in the case of the lichen planus, we find what are called as the civet bodies is what you need to remember. All of you know Negri bodies. Where do you see Negri bodies? Negri bodies are seen in rabies. Negri bodies are seen in rabies. Henderson-Patterson bodies. Just before we discuss, I'm only doing a final revision and show you how 200 single liners can be revised within 1 hour, and totally 70,000 single liners can be revised in 350 hours. Unless you go through this grilling experience of 350 hours and do the revision of the 20 single liner tweet books that I provide to you, right? It's impossible. There are no shortcuts, right? But my job as a teacher is not just giving you a video library, not just giving you the notes, not just giving you the mock tests, but to become your classmate, roommate, benchmate, table mate, and discuss with you the subject every day. All right, Doc? So, we discussed all this. JNV lesions, crooked appearance in sickle cell anemia. Bronze diabetes is a feature in hemochromatosis. Target cells are seen in thalassemia. Then hypochromic microcytic anemia. What are the 4 important conditions? Iron deficiency anemia, anemia of chronic disease, sideroblastic anemia, right? And thalassemia. In all this, you have hypochromic microcytic anemia. Cave rings are a feature because of the copper deposition that decimates membrane in case of the Wilson's disease. Just before, we have seen the radiological appearance of the osteitis fibrosa cystica, which is seen in hyperparathyroidism. Ashkoff bodies in rheumatic fever, past positive granules, typically in the histology of the Whipple's disease. Just before, we have reviewed a image-based question on Whipple's disease, right? Then Gower sign is a feature of muscular dystrophy. Honeycomb being a pneumocystis carinii. Gons focus in primary tuberculosis. Just now we have seen the radiological picture. Thymoma is a feature of myasthenia gravis. Then where do you find the light chains of the immunoglobulins going into the urine leading to the Benz-Jones proteinuria is a feature of multiple myeloma. The non-caseating granulomas are the feature of the Crohn's disease, whereas cryptapsises are the feature of ulcerative colitis. Kelte revision karna. So Kimmelston Wilson nodules in the diabetes, Herberden nodules in the distal interphalangeal joints in the case of the osteoarthritis, right? Just before we reviewed, then strawberry tongue in Kawasaki. Now, the patient can't see, can't pee, can't climb a tree. What is that called? Can't see, uveitis. Can't pee, urethritis. Can't climb, arthritis. Arthritis, urethritis, uveitis. The combination is the feature which you see in the case of the Reiter syndrome, which is a reactive arthritis, Campylobacter jejuni, post-gonococcal in any of these conditions. Now, mosaic pattern, just before we have seen a histology of the lamellar bone is seen in case of the Paget's disease. Streak ovary is a feature of Turner syndrome. Then what is the problem in Glangeman's thrombasthenia? So you should know what is von Willebrand disease, Glangeman's thrombasthenia, and Burnett-Solier's disease. So fundamentally the problem of aggregation of the platelets, one platelet to the another platelet is the problem in Glangeman's thrombasthenia. Whereas the problem of platelets adhering to the vascular endothelium is a problem in the case of the von Willebrand disease, and Burnett-Solier is what you should remember. Ataxia telangiectasia. There is IgA deficiency is a feature. Similarly, Hurtl cells, just before we have seen the multinucleated Jane cells are seen in case of the Hashimoto's thyroiditis is what you should remember. Now, neuroblastoma, where will it undergo metastasis? It undergoes metastasis to the adrenal medulla is what you should remember. In all the neuroendocrine cells, what do you find, doctor? Synaptophysin is the marker of all the neuroendocrine cells. Just before we have seen histology, appearance of Homer-Ritt stain, Homer-Ritt rosettes and Flexner-Wintersteiner rosettes. Homer-Ritt rosettes are found in neuroblastoma, medulloblastoma, and peanut tumors. Whereas the Flexner-Wintersteiner rosettes are typically found in the case of the retinoblastoma and pinealoblastoma. Ependymal rosettes in ependymoma, perivascular rosettes in ependymoma, you should not forget. Then pseudo rosettes are the feature in pineocytoma and neurocytoma. Crooked hyaline body, just before we have seen the histology, right? Histology typically is seen in Cushing's, and we have seen the histology just before. Keratin pearls is the feature of squamous cell carcinoma. Now, doctor, cells are divided into three types which you need to remember. Stable cells, quiescent cells, non-dividing cells. So now what are stable cells? Hepatocytes, smooth muscle cells, fibroblasts. Generally they don't divide, but if demanded, they can divide. Stable cells, hepatocytes, smooth muscle cells, and fibroblasts. Then quiescent cells typically are hepatic stellate cells. Then what are the non-dividing cells, doctor? Non-dividing cells, they are the cardiac muscle cells are the non-dividing cells. Once you lose the heart for somebody, you lost it forever. It can't be repaired. Then stem cells are labile cells. Then we have the stem cells which can be pluripotential, and they can differentiate into myeloid lineage, right? Lymphoid lineage, anything they can be able to divide. Then from where do hepatocytes regenerate? So you should remember there's something called oval cells in the canal of Herring. From where the hepatocytes regenerate is what you should remember. Then where will periosteal cells in bone regenerate? Osteoblasts help in regeneration. Then which cells in the muscle cause the regeneration of the myocytes? Satellite cells are the ones which regenerate the myocytes is what you should remember. Now, doctor, Now comes apudoma, APUD cells. So APUD cells are one of the neuroendocrine cells which are derived from the neural crest. And where are they located? Gastro, stomach, entero, intestine, pancreatico cells. They are gastro, entero, pancreatic cells which have an endocrine function, and they secrete the polypeptide hormones or the APUD cells. Then what is apudoma? It derives from the APUD cells, typically from ampulla of water. Then we already discussed and have seen Virchow cells and also the Hurtl cells, the LE cells. Then in chronic lymphocytic leukemia, how to recognize chronic lymphocytic leukemia? Typically, when you are preparing the peripheral smear, a CLL cell is aged lymphocyte, so it gets easily broken. And what is that called? Smudge cell appearance. Smudge cell appearance is a classical feature of the chronic lymphocytic leukemia, is what you need to remember. So we have seen Langerhans cells are the antigen presenting cells in epidermis, whereas the Langerhans giant cell is a feature of TB. In mycosis fungoides, we have, it is also called Sézary syndrome. If you look at the cell, its nucleus looks like a cerebral hemisphere. So cerebriform nucleus containing cell is the one which you find in Sézary syndrome, where you have the mycosis cutaneous T cell lymphoma, where you find Tutzer cells. Then in the skin, where do you see Merkel cells? Typically in the lower layer of the epidermis neuroglia, in the cranial and spinal ganglia, you find Merkel cells. In the retina, which cells are neuroglial? Muller cells are neuroglial. Then what are those cells in the CNS that form the glial nodule? Glial tissue is something like a fibrous tissue. Agar टीका polio BCG टीका लगाए तो आपको fibrous tissue बनेगा ना? So like that we get the glial nodules from the jitter cells, which are the microglia. So just before we have seen the flame cells, otherwise called the Mott cells, which are seen in the case of the multiple myeloma. Then the foam cells are seen in xanthomas, Niemann-Pick, and they contain the lipids. Just before we have seen the histology of Warthin-Finkeldy cells in measles. So these are all some of the favorite areas of the examiner. If you look at all the previous question bank, these points only will be asked in the form of a MCQ, right? There is nothing like a twist. We know it or we don't know it. If we don't know it, we will know it. That's all. As simple as that, right? So this is how every day we should strengthen our preparation, and one day we should tell the world there's nothing like a tough paper, twisted paper, difficult paper. Oh my God, 40 question blocked. If you have finished 70,000 high yield facts, if you have solved the question bank of the full scale grant tests and also subject wise mock tests, if you attended daily live class on YouTube freely with Dr. Murali Bharadwaj, you are born to become a winner doctor. Good night, and once more see you all tomorrow, continuing our journey in mastering 4,000 high yield facts in the tweet book for pathology. Good night.